in the interest of being efficient, we'll go through all the speakers before we have questions. And I think Kira is next. Yes.
Good morning, everyone. I want to thank the ACS and the IOM for this amazing opportunity to speak here today, and it's simply a delight to be in a room with so many amazing researchers and advocates for children with cancer. I'm going to be speaking today about poverty in pediatric oncology and future directions for outcomes measurements, and I'm really going to build a little bit on some of the data that you saw presented in the previous presentation, and hope that I can take you through some interesting insights that we may have here. I have no conflicts of interest to disclose. Briefly, I'm going to go through what I view as the scope of the problem with regard to poverty in pediatric oncology. I'll give you some operational definitions just to make it clear what I'm speaking about. A brief background of the context of poverty in pediatric oncology and pediatrics in general. And then really I want to focus most of the talk on our current gaps in our knowledge and some early work that our group has done to try and fill these. Then moving into some concrete recommendations for where we might go from here as a group. So in the talk that we just heard, there was some data presented looking at the relationship between insurance coverage and outcomes for children with AML. I'm going to expand on that to argue that potentially measurement of social determinants of health in pediatric oncology represent a significant gap in our research base and a potential opportunity for significant improvements in outcomes for our children. So health disparities, I think everybody know, are something that there are multiple national initiatives to eliminate in the United States. The ACS has voiced that health equity in cancer is a priority. The federal government has published Healthy People 2020 goals, which identify achieving health equity, eliminating disparities, and improving the health of all groups as a major federal goal. In the adult cancer world, I think this has been perhaps slightly better addressed. There's a robust body of literature in the adult oncology community from which we know that race, ethnicity, and SES drive cancer incidence and outcomes in adult oncology. I think the adult world has benefited a little bit from clear mechanisms that perhaps may link these social determinants of health with outcomes that are not necessarily able to be extrapolated to the pediatric oncology setting. That said, I think we can learn a little bit from what they've done. There are limited data in pediatric oncology with regard to the relationship between social determinants of health and our clinical outcomes, but I'm going to show you some of those data today and talk a little bit about where we can go. So the scope of the problem I would say is three-pronged. The first, poverty is correlated with negative health outcomes in pediatric primary care and subspecialties. This has been well established in the literature. How poverty impacts pediatric oncology outcomes and quality of life is less well understood. Pediatric oncology providers do not routinely consider poverty to be a mediator of clinical outcomes or quality of life, nor do we assess financial hardship as a consequence of therapy throughout our treatment courses. That being said, if in fact there are linkages between pediatric oncology and our clinical outcomes, I would argue that those relationships are really only meaningful in the clinical setting if we can identify targetable measures on which we can actually act as clinicians. And with that, I will say that SES is really one of those variables that as researchers we generally control for in our analyses using proxy measures because we don't really know what else to do with it. If it's possible to bring those measures up front in our care strategies, I think that's where we have some opportunities for shifts in our care. Here, I just want to quickly start going through a couple definitions of poverty. I've put on this slide multiple measures that you're probably familiar with in the literature. And again, poverty is a multi-dimensional construct. There's no one right measure of poverty. All of the things up on this slide are probably things you've seen as being used as proxies for poverty in various research previously. I'm going to focus on two of these today. The first is the one that's probably most commonly used, and that's income poverty. This is exactly what it sounds like. It refers to a household income. That can be either family reported or more commonly a proxy for household family income, often derived from US Census measures that are linked to zip code is used in the literature. And income is often transformed into a percentage of federal poverty level, 100% FPL or 200% FPL. And that has been used as a standard to identify what is considered the minimal amount of income a household needs to meet its basic needs, such as putting food on the table, keeping a roof over your heads, keeping the heat on in a house. I'm going to focus today on a slightly different measure of poverty, which is material hardship, and this refers to concrete resource needs, such as food, housing, and energy that a family needs to survive regardless of a child's diagnosis. With that, I want to very quickly go through the operational definitions I'm going to use here. I'm going to put up the measures that have been used in research published to date and in the research that I'm going to show you. Food insecurity is defined as when a family does not have enough money to put adequate food on the table to meet the metabolic demands of the people in the household. This is the standardized U.S. household food security scale, which is used to measure this. To screen positive for being food insecure, a family has to endorse 2 of these items. Energy insecurity, I mentioned as the second of the concrete resource needs. These 4 questions are used to screen for energy insecurity. To screen positive for energy insecurity, a family has to endorse 1 of these items. You can see, as with food insecurity, these are all very concrete measures. And finally, housing insecurity. Here again, to screen positive for housing insecurity, a family has to endorse 1 of these measures, either that they live in an overcrowded housing with 3 or more people per bedroom, they've moved more than 3 times in the last year because they did not have access to stable housing, or they're doubled up, meaning that they actually don't have a house to live in and they've moved in with somebody else and perhaps sleeping on the couch. So to give you that background context and the data that we have, child income poverty. The current rate of child income poverty in the United States is the highest in the past 2 decades. 23% of children in the United States, that's 16 million, are currently living in poverty. That's 1 in 5 children who live below 100% of federal poverty level in the US, which would be a household income of about $24,000 for a family of 4. Child material hardship. In the United States, the federal government collects data on food insecurity on an annual basis. The most recent numbers are for 2012, and they reflect the fact that, again, 1 in 5 children lives in a food insecure household in the United States. This is the background. We know that childhood cancer takes all comers, and so this is the context in which we're providing care for our children. What does that mean for child health? So I mentioned that there's a robust body of literature in the general pediatrics world, which have demonstrated clear relationships between poverty and negative child health outcomes. Specifically, children who live in middle and high poverty areas experience higher all-cause mortality. We know that children who live in poor families are more likely to be in fair or poor health when you compare them to their non-poor counterparts. And we know that children who live in families with material hardship, as I defined for you previously as being food, housing, or energy insecurity, have higher rates of hospitalization, fair or poor health, injury, and infectious disease. Now, does this extrapolate to the subspecialty setting, where we might argue that children are hooked into an intensive medical scenario? They have access to psychosocial services that are potentially not available in the general pediatrics population. I'm going to quickly go through some of the data that exist, but I'm also going to say that we don't really know the answer to that because this is not an area of investigation that has been robustly pursued by pediatric oncology. What we do know is that childhood cancer treatment is associated with significant financial burden for families. I'm going to show you some of those data, but recent publications in the last 5 years have demonstrated that at least 1 in 4 of our families report losing more than 40% of annual household income as a result of their child's cancer treatment. There's emerging data that family income poverty is associated with decreased overall survival for children with cancer in the United States. And I think those emerging data are compelling with regard to arguing that this is something that we potentially should be studying more. And then recently, there have been some compelling publications which have demonstrated that family income poverty may be associated with decreased adherence to oral chemotherapy. Dr. Bhatia and colleagues published impressive work looking at the relationship between adherence to oral chemotherapy and increased rates of relapse in children with acute lymphoblastic leukemia. This relationship was true for their overall cohort, although it did not hold in all of the racial and ethnic subsets that they looked at. All that being said, coming back to the third point I made at the beginning, perhaps all of this doesn't matter if there are not targetable measures within this domain. And I would just put this slide up there to say that, again, the general pediatrics world is perhaps a bit ahead of us in that they have identified the fact that there are ways to intervene on some of these concrete measures of poverty in ways that actually directly impact child health outcomes. So I've put up here each of the 3 domains of material hardship. Here I gave examples of using using existing governmental resources to address these, each of which has been shown in general pediatrics to then decrease the negative health outcome that is associated with those. The final bullet point that is up there is a recent randomized trial that was conducted in the general pediatric setting that demonstrated that simply screening for material hardship in a clinic-based setting increased familial receipt of the above resources, which then have been linked to improved child health outcomes. So where are the gaps and needs? Disparities in pediatric oncology due to social determinants are not currently addressed in a systematic fashion by protocol design or our care context, I would argue. And I think there's really two prominent gaps that I'd like to speak to. The first is, I would argue that there's no upfront systematic collection of measures of social determinants in our clinical trials design, which we've heard some today about the fact that this really is the backbone of the care that we provide. And it's the opportunity that we generally have for collecting data, which we're then linking to our outcomes of interest, specifically overall survival, event-free survival, relapse, acute and late toxicities, and quality of life. The second point is that when we have measured social determinants, we've relied on non-targetable measures. And so again, coming back here to this idea of using proxy zip code incomes, which I'm not really sure what you do with those as a clinician, even if you can show that they're linked to outcome. Or for instance, using parental education. Again, I don't know how you change that. I'm going to now quickly go through some data that our group has recently generated, and then I'd like to get to the recommendations. So with the background that I just gave you, one of our initial questions was, in fact, is there a relationship between poverty and outcomes that we see in the tertiary care academic medical setting for children that we treat? This was a retrospective analysis of 2 iterative phase 3 clinical trials that were run by the Dana-Farber ALL Consortium, which is a significantly smaller consortium than COG, but does treat children with newly diagnosed ALL at multiple sites across the United States. This utilized that proxy zip code income as the measure of poverty for families. And families were divided into 2 categories: children living in what were categorized as high poverty areas based on census zip code, where more than 20% of families are in poverty, and low poverty areas. There were 575 children between the ages of 1 and 18 included in this analysis. They all received care at one of 6 tertiary care academic medical centers on clinical trial for ALL. And the punchline, as I put up here and as you can see in the graph, was that there was a significant difference in overall survival for children living in high poverty areas as compared to low poverty areas, such that those in high poverty areas had worse overall survival. The subsequent analysis we did trying to get at why that might have been demonstrated that it's probably related to the types of relapse that they're experiencing. And children living in high poverty areas were more likely to experience early relapse, which in the ALL world correlates with a worse outcome, as early relapses are often more difficult to salvage. These preliminary data then moved us into a couple of other studies, really getting back at that idea of those are compelling in that our outcomes may be related to this, but what can we potentially target in the clinical setting? This is a prospective longitudinal study that was conducted at a single site at Dana-Farber. We enrolled 100 families at the time of their child's cancer diagnosis and asked them to complete 2 face-to-face surveys. One of those was done at the time of diagnosis, and one of those was done 6 months later into chemotherapy treatment. We included all diagnoses of cancer, so this was not limited just to leukemia. And the primary aim of this study was to identify the prevalence of material hardship, that targetable measure of poverty in our patient population, with the hypothesis being that while it's prevalent in general pediatrics and targetable in general pediatrics, perhaps within our psychosocial care model of pediatric oncology, we would already be addressing these concrete resource needs. The results you can see up there in panel A, these are our baseline data. This is what families reported to us at the time of their child's diagnosis, so how they're coming into us. And here you can see I've stratified the cohort into low-income families, those living at less than 200% federal poverty level, and high-income families, those at greater than 200% federal poverty level. But the punchline was that 20% of our newly diagnosed families reported food, housing, or energy insecurity in the 6 months prior to the child's diagnosis of cancer. Panel B shows 6 months into chemotherapy treatment, where we had hypothesized we would see decreased rates from baseline after integration into our care context, where they were hooked up with a primary psychosocial provider and had access to a social worker who addressed concrete resource needs. And instead of seeing a decrease in material hardship, we saw an increase such that 6 months into chemotherapy, 30% of our families were reporting food, housing, or energy insecurity. The final bullet point at the bottom there gets to a secondary aim of this study, which was again looking at that financial hardship and are things changing financially for families, and it seems that the answer to that is yes. Again here, as in the preliminary data I showed you, 25% of our families reported annual income losses of more than 40% in those first 6 months of chemotherapy, specifically due to their child's chemotherapy treatment. And then the final study, and I will move on as I'm running out of time here, this was a cross-sectional study that was done in our bone marrow transplant population. We asked families using the same survey to complete a one-time face-to-face survey 6 months post-allogeneic bone marrow transplant, so while their child was still on home isolation after transplant. Again, the primary goal of this study was to identify the rates of material hardship in our patient population, to identify whether this was prevalent and potentially targetable. And again here, rates were above what we had hypothesized. 38% of our families reported that in the 6 months post-transplant, they had experienced food, housing, or energy insecurity. And then we additionally did an exploratory analysis here, trying to see whether there may be a relationship between this measure of material hardship and child outcomes in the post-transplant setting. We were not powered to do a controlled analysis, but in our univariate analysis, we did find that children in homes with material hardship had an increased risk of graft versus host disease, which is a primary medical complication following bone marrow transplant, as compared to those children living in homes without material hardship. So the summary of that, the clinical implications. I think these are perhaps data that suggest poverty may be mediating some of our pediatric oncology outcomes. Nearly 1 in 3 of our families report that they're experiencing material hardship during therapy, and that's early on during therapy. The studies that I showed you were 6 months into chemo. We know that many of our families are in therapy for much longer than that, and we don't yet have the data to see what the trajectory is over time. The research implications, I think, are interesting, and I'm going to move immediately into recommendations. I would posit that material hardship is a targetable measure of poverty here, and I think that has big implications for our field. The opportunity for us is that poverty crosses all histologic subtypes of cancer. It crosses all risk group stratifications. And so unlike molecular targets, this is something widely prevalent in all of our families. It's likely a component driving disparities in outcomes, and it's something we can do something about. My recommendations. From a research standpoint, I think as a field, we need to engage in a systematic and standardized collection of sociodemographic variables in upfront consortium clinical trials. I would argue that having a working group to identify consensus domains and measures would be an important first step, but then collecting these measures up front so that we can link them directly to our outcomes of interest, overall survival, event-free survival, early relapse, is essential if we're going to target this and improve this potential driver of outcome. My clinical recommendation would be that, forgetting whether this is linked to clinical outcomes, integration of systematic screening for material hardship in the clinical setting can happen immediately, and it's an opportunity for targeted intervention for quality of life for families, because regardless of relationship with relapse or overall survival, material hardship in families of children being treated for cancer is certainly a source of suffering that we can do something about as a field. And finally, from a policy standpoint, I think there are multiple opportunities for reform efforts, both at the local hospital level, state and federal level, and then perhaps at the insurance payer level. And I am out of time. So with that, I want very much to thank my mentor, Joanne Wolf, and thank you so much for your attention.